Bismillahirrahmanirrahim. Quote of the day. We are what we repeatedly do excellence, therefore it is not an act but a habit. Assalamu alaikum. I am Dr. San Mahmood. Today I am presenting on anemia under current supervision of my professor, Dr. Saira Afzal. Learning outlines. What is today we learn what is anemia, pathophysiology, normal values, types, classification, risk factors, causes, symptoms and signs, investigations, management, treatment, and recent updates. Learning outcome. At the end of this presentation, participant will have a broad overview of anemia, its type and classification, how to identify different anemias through lab investigation and recognize signs and symptom management of anemia will also be understood in depth. What is anemia? Anemia is the decrease in the hemoglobin, hematocrit, and number of RBC count resulting in lower ability for the blood to carry oxygen to the body tissue. According to WHO, anemia is a major public health concern, mainly affecting young children, pregnant and postpartum women, and menstruating adolescent girls and women. Low and lower middle income countries bear the greatest burden of anemia, particularly affecting population living in rural setting in poor households and who have received no formal education. Globally, it is estimated that 40% of all children aged 6 to 59 months, 37% of pregnant women, and 30% of women 15 to 49 years of age are affected by anemia. Anemia caused 50 million years of healthy life lost due to disability in 2019. The largest cause were dietary iron deficiency, thalassemia, and sickle cell fat and malaria. Now, pathophysiology. Pathophysiology includes decrease in the red blood cells, hemoglobin, and hematocrit level leads to diminished oxygen carrying capacity, leads to hypoxia and hypoxia-induced effect on organ function. It leads to signs and symptoms of anemia. Normal values of anemias, normal values of hemoglobin in men in more than 30 gram per deciliter, in women more than 12 gram per deciliter, in pregnant women more than 11 gram per deciliter, infant from 2 to 6 months more than 9.5 gram per deciliter, children from 6 months to 24 months more than 10.5 gram per deciliter, 2 years to 11 years more than 11.5 gram per deciliter, and children from 12 years more than 12 gram per deciliter. Classification of anemias includes on the basis of causes and on the basis of morphology. On the basis of causes, it divided into blood loss, inadequate production of normal blood cells, excessive destruction of blood cells. On the basis of morphology, anemia classified on normocytic, microcytic, and microcytic. Types of anemia. Clinically, anemia has following types: iron deficiency anemia, megaloblastic anemia, hemorrhagic anemia, pernicious anemia, aplastic anemia, hemolytic anemia. Hemolytic anemia also divided into thalassemia and sickle cell anemia. Iron deficiency. In iron deficiency anemia, excessive loss of iron, less intake of iron. Women are at high risk for muscle blood loss and growing fetus in pregnant women. In megaloblastic anemia, less intake of vitamin B12 and folic acid. Red bone marrow produces abnormal RBC due to cancer drugs. In pernicious anemia, inability of stomach to produce intrinsic factor which absorb vitamin B12 in small intestine. In hemorrhagic anemia, excessive loss of RBC through bleeding, stomach ulcer, and menstruation. In hemolytic anemia, RBC plasma membrane rupture may be due to parasite toxin and antibiotics. In thalassemia, less synthesis of hemoglobin, more presence of Mediterranean Sea population. Hemorrhagic anemia, excessive loss of RBC through bleeding, stomach ulcer, and menstruation. Hemolytic anemia, RBC plasma Membrane rupture may be due to parasite, toxin, and antibiotics. Thalassemia, less synthesis of hemoglobin, more presence of Mediterranean Sea population. In sickle cell anemia, hereditary blood disorder characterized by RBC that assume an abnormal and sickle shape. In aplastic anemia, destruction of red bone marrow, cause of toxin, gamma, and radiation. Normocytic, normochromic, normocytic anemia, normal MCHC, normal MCV. These includes anemia of chronic disease, hemolytic anemia, anemia of acute hemorrhage, aplastic anemia. Hypochromic macrocytic anemia, low MCHC, low MCV. These includes iron deficiency anemia, thalassemia, and anemia of chronic disease. Normochromic macrocytic anemia, normal MCIC, high MCV. This includes vitamin B12 deficiency and folate deficiency. Risk factor of anemia includes poor socioeconomic class, multiplicity, teenage pregnancy, menstrual problem. Uh, the dietary factor that includes in anemia that cause in anemia, low vitamin C, excess folate, excess tea, coffee, low iron here, iron, heme, iron, or fat diet. With social and physical factors that includes in anemia, poor digestion, alcohol abuse, depression, candle burning, GIT disease, and poverty. Demographic factor includes elderly, female, widow, teenager, and immigrant. This factor of iron deficiency anemia include pregnancy 43%, nutritional inadequacy 15%, various gastrointestinal pathologies 15%, menorrhagia 9%, hemorrhoids 8%, hookworms 8%, and hematuria 2%. Causes increased requirements in menstrual female pregnancy, lactation, growing infant, and children erythropoietin treatment. Increase loss in GI bleed, menorrhagia, persistent hematuria, intravascular hemolytic anemia, regular blood donors, parasitic infection. Decrease intake in vegetarian diet, socioeconomic factor, decrease absorption in upper GI pathology, gastrectomy, and medications. Common symptoms of anemia: easy fatigue and loss of energy, usually rapid heartbeat, particularly with exercise, shortness of breath, and headache, particularly with exercise, difficulty in concentration, dizziness, pale skin, leg cramps, and insomnia. Uh, Signs of anemia include chylomicronemia, angular stomatitis, brittle hair, atrophy of papilla of tongue, dysphagia and glossitis, Palmer-Wilson syndrome, brittle nails. Symptoms of anemia includes eye symptoms, yellowing skin, paleness, coldness, yellowing, respiratory shortness of breath, muscular weakness, intestinal includes change stool color. Central includes fatigue, dizziness, fainting, blood vessel, low blood pressure, heart palpitation, rapid heart rate, chest pain, angina, heart attack. In spleen, enlargement of spleen. Investigation. The red cell population is defined by quantitative parameters and qualitative parameters. Quantitative parameters include volume of packed cells, hemoglobin concentration, red cell concentration per unit volume. Qualitative parameter includes mean corpuscular volume, corpuscular hemoglobin, mean corpuscular hemoglobin concentration. Hematocrit is the proportion of the volume of blood sample that is occupied by RBC. Men 42 to 52%, female is 36 to 48%. Red cell count, total number of red cell per unit volume of blood sample. In men, it is 4.2 to 5.4% for millimeter cube. In women, 3.6 to 5. Cell volume of hemoglobin concentration, it is the amount of hemoglobin per unit volume of blood. In women, 12 to 16 gram per deciliter. In men, in 14 to 17 gram per deciliter. Labs, mean corpuscular volume, it is the average volume of RBC. Normal range is 80 to 10, 80 to 100. Mean corpuscular hemoglobin, it is the average hemoglobin count per RBC. Normal range is 27 to 31%. Mean corpuscular hemoglobin concentration, it is the average concentration of hemoglobin in given red cells volume. Its normal value is 32 to 36 gram per deciliter. Management care objective determine the cause of anemia. The etiology of is often multifactorial. Even when there is an obvious cause, investigation of serious underlying cause is recommended. Aim of treatment, normalize hemoglobin level and red cell indices, replenish and restore. Individualized disease specific management depending on underlying cause. Lifestyle management, it is recommended that patients with iron deficiency receive dietary advice. Non-pharmacological management, tea and coffee inhibit iron absorption when consumed with the meal or shortly after meal. Vitamin C is also a powerful enhancer of iron absorption from non-meat food when consumed with a meal. The size of vitamin C effect on iron absorption increase with the quantity of vitamin C in the meal. Germination and fermentation of cereal and legumes improve the bioavailability of iron by reducing the content of phytate, a substance in food that inhibit iron absorption. Promote and support exclusive breastfeeding for about 6 months, followed by breastfeeding with appropriate complementary foods, including iron rich through the second year of life with decreased chances of iron deficiency anemia in child. Recommended diet allows in men, adult men 8 milligram, woman adult 8 milligram, adult 18 mg, the age 19 to 50, pregnant in pregnant 27 milligram, lactating mother in 9 milligram to 10 milligram, adolescent age 9 to 18, 8 milligram to 15 milligram, and children age 4 to 8 in 10 milligram, infant 7 to 1 year 11 milligram, infant birth to 6 months 0.27 milligram. Management, complementary parasitic control measures, anti-helminthic therapy with 400 mg of single dose of albendazole is given to eliminate hookworm before the initiation of iron and folic acid therapy. Child less than 200 mg per day, single dose of albendazole. Pregnancy albendazole is contraindicated in first trimester, but it can be given in second and third trimester. Dosage, the treatment for 6 to 24 month of age, dosage 12.5 milligram iron plus 50 microgram folic acid daily, normal low birth weight, duration in normal in 6 to 24 month of age and in low birth weight 2 to 24 month of age. Treatment of mild and moderate anemia. Group in children 2 to 5 years, 20 to 30 milligram iron per day. Children 16 to 11 years in 30 to 60 milligram iron per day. Adolescent and adults 60 milligram of iron per day. Anemia will correct within 2 to 4 months of if proper dose of iron is given and cause iron deficiency is corrected. Then continue iron therapy and additional 4 to 6 months in adult after the hemoglobin becomes normal to replenish the iron stores. Treatment of severe anemia. Age less than 2 years, 25 milligram iron plus 100 to 400 microgram folic acid daily for 3 months. 2 to 12 years, 60 milligram iron plus 400 microgram folic acid daily for 3 months. Adolescent and adults include pregnant women 120 milligram iron plus 400 microgram folic acid daily for 3 months. After completing the 3 months of therapeutic supplementation, pregnant women and infants should continue the preventive program of iron supplementation. treatment of pregnant women prevalence of anemia in pregnancy, 40% in population, 60 dose 60 milligram iron, 400 microgram folic acid daily, duration 6 months in pregnancy and continue to 3 months for postpartum. Iron absorption may be decreased by antacid and supplementation supplement containing aluminum, magnesium, calcium, zinc, proton pump inhibitor. Space administration apart by at least 2 hours. Oral iron preparation may cause nausea, vomiting, dyspepsia, constipation, diarrhea, or dose stool. Strategies to minimize these effects include start a lower dose of increase gradually over 4 to 5 days, given divided dose are the lowest effective dose are taking supplements with meals. Although sustained release iron preparation trend towards less gastrointestinal side effect, they may not be as effective as standard film coated product due to reduced poor iron absorption. This is anemia in children, a severe deficiency of hemoglobin in 5.7% and in moderate deficiency is 48%. More than half of Pakistan children are anemic and 5.7% are severely anemic. The prevalence of anemia is slightly higher among boys than girls. Children in rural area are more likely to be anemic than in urban area. Trend of anemia in Pakistan, the prevalence of anemia has been consistently higher since 2001 when it is stood at 50.9%, then rose to 61.9% in 2011 and declined to 53 to 7%, 53.7% in 2018. Anemia among adolescent girls, more than half adolescent girls in Pakistan are anemic. Adolescent girls in rural area are more likely to be anemic than their counterpart in urban area. Anemia among women of reproductive age is severe deficiency is 1% severe deficiency, 41.7% in moderate deficiency, and in 57.4% in normal. About 41.7% of women of reproductive age are anemic with slightly higher proportion in rural than urban setting. Now it's time for recent updates. An article published in 2025, PICA Practice Anemia and Oral Health Outcomes, a systematic review. PICA is a non-nutritive eating behavior. The potential impact of PICA on oral health and assumption between PICA and anemia are under studied. We examine the current evidence on the relationship between PICA practice anemia and oral health outcome. We use population intervention control and outcome terms to create meshed terms to assess the relationship between PICA and iron deficiency anemia, the relationship between IDA and oral health, and relationship between PICA anemia and oral health outcomes. From 4159, such article 89 met the inclusion criteria. Studies were published between 1959 and 2021 from 33 countries. Nearly half of these studies were reported. The most common PICA included geophagia, phagophagia, myelophagia, and paper, and others such as pica form and hair. Pica practice were slightly associated with IDA, but showed not statistically significant trend of association with oral health outcome. Pica was strongly associated with anemia and IDA, tooth absorption, abrasion, and dental caries were observed among Pica users. Future studies could define the strength of PICA's oral health association and the potential mediators such as anemia. This article also published in 2025, uh, deciphering the role of hepcidin in iron metabolism and anemia management. One of the most common diseases worldwide in anemia, which is characterized by insufficient erythrocyte production. This review focuses specifically on anemia caused by Deficient effective hepcidin production. Hepcidin, a peptide hormone produced primarily by liver cell, play a crucial role in the regulating iron level by controlling its absorption. Hepcidin mechanism of action involve binding to the ferroprotein iron transporter, causing its internalization. Hepcidin is a key regulator of iron metabolism, play a pivotal role in preventing iron release in the plasma from absorption, erythrocyte, and macrophages. Despite its potential as a biomarker, the clinical application of penicillin is hindered by the lack of commercially available clinically validated assay. This review aimed to provide a comprehensive overview of hepcidin role in regulating blood iron concentration and elucidate its implication in the pathogenesis of various anemia subtypes, paving the way for its future application in research and clinical practice. Now it's time for MCQs. A researcher want to do study regarding the anemia in the child under the age of 5. His supervisor told him to take the sample by considering the global prevalence. What is the global prevalence of anemia in children less than 5 years of age? A 38%, B 39%, C 40%, D 41%, and E 42%. It's C 40%. A boy of 10 years of age admitted for an operative with HB level of 10.5 in the theater. There was a conflict between the surgeon and anesthetics regarding the HB level of the patient. According to the anesthetics, patient is anemic, but according to surgeon, he is not. What would be the minimum value for HB for 10 year of old, old boy? 10.5 gram per deciliter, 9.5 gram per deciliter, 11.5 gram per deciliter, 12.5 gram per deciliter, and 13 gram per deciliter.
C. Answer is C.
Yes, it's C. A 30-year-old patient presented in the OPD patient with diagnosed as gastric ulcer 1 year back and remained untreated. In CBC, HB was 9, MCIC was normal, and MCV was high. So, what is the diagnosis of this patient? Aplastic anemia, pernicious anemia, iron deficiency anemia, hemolytic anemia, and anemia of chronic disease.
E.
It's B, pernicious anemia. A 21-year-old boy fainted in his college class. Upon taking to emergency, his father gave history of not taking any kind of meat from last 8 years. His CBC show HB4, MCIC, and MCV was lower than normal value, and all the cell line are normal. What will be the top different diagnosis for this patient? Iron deficiency anemia, megaloblastic anemia, hemolytic anemia, aplastic anemia, and folate deficiency anemia.
E.
Yes, it's B. A female patient of 60
B.
went to a doctor and was concerned about her health. In history, she said that she takes 12 cups of tea and has depression. What will the level of risk of having anemia in this patient? Risk of anemia, high risk of anemia, very low risk of anemia, no risk of anemia, or very high risk of anemia.
E.
Yes, it's E, very high risk of anemia. A 50-year-old patient presented in the outpatient department to a pulmonologist. He complained of having shortness of breath. Chest was clear in examination. He was having history of diabetes, hypertension, and dermatitis. HP level is 7 gram per deciliter. What is the most probable cause of shortness of breath in this case? Diabetes, hypertension, bronchitis, anemia, and dermatitis.
D.
Yes, it's D. A patient presented in a mother care center. She was breastfeeding for a 5-month-old child. She was concerned about the macronutrient intake in the diet. What will be the daily iron requirement of this mother? 6 to 8 milligram per day, 9 to 10 milligram per day, 18 milligram per day, 27 milligram per day, 14 to 15 milligram per day. Nine to 10 milligram B. What if I were old patient presented in the OPD with complaint of early fatigue? He was diagnosed as iron deficiency anemia, and anemia was corrected after 2 to 4 months of iron intake. For how much more a month iron is required to replenish the iron stores? 2 to 3 months, 4 to 6 months, 5 to 6 months, 1 to 2 months, and 7 to 8 months. It's be 4 to 6 months. An 11-year-old female patient presented in the emergency and was diagnosed as severe form of iron deficiency anemia. What is amount of iron and other supplements should be given to the patient as a therapeutic management of severe anemia? 60 milligram iron and 600 microgram folate for 3 months, 60 milligram iron and 400 microgram folate for 10 months, 70 milligram iron and 300 microgram folate for 8 months, 100 microgram iron and 60 microgram of folate, 98 microgram of iron and 78 microgram of folate. It's A, 60 microgram iron and 400 microgram folate for 3 months. In 2021, 40 COVID affected pregnant ladies gave birth to low birth weight child. After doing research, it was observed that lack of a specific nutrient causes this low birth child. So, what is that nutrient which causes low birth weight child in COVID affected pregnant ladies? Vitamin B, vitamin C, iron, magnesium, and calcium. It's C, iron. This is key for our MCQs. This is our YouTube channel link. Thank you.